Thank you for joining our panel today. I'll reiterate this panel discussion is titled New Kid on the Block, an Answer to the Medicaid Problem. Our panelists up here, I'm going to follow Arlene's format and just introduce all of them in the order that they'll be speaking and then let them get to it because they're far more knowledgeable than I am about Medicaid. And I'd like to note, like our previous panel, this panel represents a spectrum of views on Medicaid and on Medicaid block grant, on the concept of a block grant. I think if there's one thing that they might agree on is that the current state of Texas, the Texas Medicaid program, is unsustainable and in need of some reforms. And what those reforms are is a matter of debate. What we do know is over the past decade, that Texas has more than doubled its spending on Medicaid. Last year, the state spent an estimated $10.7 billion in general revenue funds, state funds, on the program, compared to just $4 billion in 2001. And that growth is projected to continue over the next decade, consuming an ever larger share of the state budget. The program is currently accounts for a quarter of the state budget, 25% roughly, and that share is expected to grow even without the expansion of the Medicaid program called for under Obamacare. Funding this program has proven difficult in recent years. As I'm sure most of you know, the current Medicaid budget has a shortfall of about $4.7 billion that the legislature is going to have to backfill before it tackles the 2014-15 Medicaid budget. And as we go into the legislative session, lawmakers are going to have to devise a Medicaid budget that takes account for an ever-increasing enrollment, an influx of enrollees, the so-called current eligibles. Even without expanding Medicaid under Obamacare, we'll have a large number of people who will join Medicaid to fulfill the law's individual mandate. The Texas Health and Human Services Commission estimates these new enrollees will cost nearly $1 billion, more than $400 million of which will be state funds. In short, the cost of our Medicaid program are rising, and it's rising too quickly. Meanwhile, it's increasingly difficult for Medicaid enrollees, as we've heard, to find a doctor who will see them. A recent survey found that now only 31% of Texas physicians will accept new Medicaid patients, down from 67% in the year 2000. That's a pretty drastic and consistent decrease. And there's a couple reasons for this. One is the onerous administrative burden of treating Medicaid patients, combined with low reimbursement rates, mean that more Texas physicians are just opting out. And this leaves current enrollees with declining access to care. And it's worth asking the question, how low are we going to let that percentage drop, that percentage of physicians who will take Medicaid patients drop until we do something about it? Is it 15%, 10%? So what to do about these problems? The funding structure of our Medicaid system makes controlling costs extremely difficult. Now, with nearly 60% of our state Medicaid budget coming from federal matching funds, there's an incentive for states to spend more, not less, and thus pull down an ever larger share of federal dollars. It's inherent to the system. But by intermingling state and federal finances, Medicaid splits political accountability for its costs and makes cutting the budget extremely difficult. For example, a state with a 60% federal matching rate, legislators hypothetically would have to cut $250 from the Medicaid budget to save $100 in the state budget. And that's an unappealing proposition, and it's one that politicians are unlikely to make in any state. And that brings us to the question of fundamental reform. Some have argued, including the Texas Public Policy Foundation, that without changing the system by which we fund our Medicaid program, we cannot control costs over the long term. And the approach that we have advocated is to do away with the system of federal matching funds altogether and instead fix the amount of federal funding for the Medicaid program with a block grant. Now, that's all I'm going to say about it, because I want these guys to talk about the block grant. They're more qualified to do so than I am. And I'll introduce them all together in the order that they'll speak. Our first panelist is James Capretta. He's a fellow at the Ethics and Public Policy Center in Washington, D.C., and was an associate director at the White House Office of Management and Budget from 2001 to 2004. Okay, problem down there. He had responsibility there for healthcare, Social Security, education, and welfare programs. At the Ethics and Public Policy Center, Mr. Capretta studies and provides commentary on a wide range of public policy and economic issues with a focus on healthcare and entitlement reform. His essays and articles have appeared in numerous print publications, online publications, including the Wall Street Journal, USA Today, Politico, and many others. And most recently, in fact, he is the lead author of a study published by the Texas Public Policy Foundation last month entitled Assuring a Future for Long-Term Care Services and Supports in Texas, which outlines Medicaid long-term care reform in the context of a block grant, which I believe we have an executive summary of the report here today. Our next panelist is the Honorable Kyle Janik. He is the Commissioner of Texas Health and Human Services. Dr. Janik was appointed Texas Health and Human Services Executive Commissioner on September 1st, 2012 by Governor Perry. As head of the Texas Health and Human Services Commission, Dr. Janik provides leadership and strategic direction to the health and human services system in Texas, overseeing operations of 5 health and human services agencies, including more than 56,000 employees, combined annual budgets of $30 billion, serving more than 4 million Texans. A lifelong Texan, Dr. Janik was born and raised in Galveston, served 8 years in the Texas House of Representatives, and was elected to the Texas Senate in 2003, where he served for more than 5 years. Our third panelist is Ann Dunkelberg. She is the Associate Director for the Center for Public Policy Priorities. Ms. Dunkelberg joined the center in 1994 and is one of the state's leading experts in policy and budget issues relating to healthcare access. In 2007, she was named Consumer Advocate of the Year by Families USA in Washington, D.C. And before going to the Center for Public Policy Priorities, she served as Program Director for Acute Care in the Texas Medicaid Director's Office and spent 6 years with the Texas Research League, where she authored numerous reports on Texas health and human services issues and tracked state health and human services budget issues. With that, I will turn it over to Mr. Capretta for our first presentation.
Well, thank you very much. I'm so pleased to be here. Let's see here. Make sure I can get my slides up. There it is. Thank you. Okay, ready to go. Good morning. Very, very pleased to be here. Thanks so much to the Public Policy Foundation here in Texas for inviting me and for bringing me into the family of folks that they have working on their projects. It's I didn't know about this until a year or two ago, and very, very impressed with the work and the ambition of the effort to improve public policy in this state. I want to start because I come from Washington, so therefore I'm part of the problem. And I want to start with a little bit of a federal perspective, actually. It's quite true that this is a massive budgetary issue at the state level, but we can't ignore the fact that it's a huge, huge issue at the federal level, too. We're running trillion-dollar deficits, and the conversation over the last year or two has been about what's causing our fiscal problems nationally. And I like to use this chart to provide what I think is basically the reason why we're having fiscal problems, and we're going to have fiscal problems going forward. And it has to do with the big three, as I call them. We've moved as a country over the last 4 decades from spending about 4.4% of GDP, over here on the far left in 1972, on the big three entitlement programs, Social Security, Medicare, and Medicaid, 4.4% of GDP. If you look across the top there, our average federal income or federal tax revenue take from the economy has been about 18% of GDP. So back in 1972, there was a lot of room between 4.4 and 18 to do a lot of other stuff, like build roads, maintain a standing army, have a navy, protect our borders, et cetera, okay? Fast forward to 2012, going on 2013, we're at about 10% of GDP on those 3 programs. So we've added 5.6 percentage points of GDP to spending in that category of the budget, the big entitlement programs. And we didn't really change much else in terms of the revenue take. The total revenue take of the government is still roughly around 18% of GDP on a historical basis. There are ups and downs. And that means that we've squeezed out an awful lot of other things to make room for that. What did we squeeze primarily? We squeezed national defense. Believe it or not, we're still fighting 2 wars, but national defense is way, way below where it used to be in the post-war era, immediately after World War II, going through Vietnam. We spent a lot more of our budget on national defense. We squeezed it way down when the Cold War ended. That essentially made room for these entitlement programs. But going forward, if we just allow the programs to run on their current trajectory, they're likely to head up toward another about 16% of GDP in another 2 decades. Medicaid is a huge, huge part of this. Obviously, the fight at the moment is the president wants that dotted line, which is the historical revenue take, not to be flat, but to go like this, okay? He's basically arguing that the historical revenue take of the federal government will no longer satisfy, and he wants to move that number up to 20, 22, maybe even 25% of GDP. So that's really what the fight is about in our budget. If you want to know why we're having fiscal problems now nationally, this is the reason. Why we're going to have them in the future, this is the reason. Medicaid is a big, big part of it, as I just said. It was obviously in that chart, but just isolating the numbers. Going back to 1971, we were spending well below 3% of GDP on Medicaid at the national level. Now it's about 1.8% of GDP. And of course, John already mentioned all this, but at the state level, it's gone up very, very dramatically. With spending just about a decade ago at about 22% of total state revenue going to the program. Now it's going up to about 26, 27%. So huge movement in terms of how much of the state budget is now going toward the Medicaid program. What are we going to do about it? Well, the basic argument, and I'm going to talk about this for a minute, and then I'm going to talk a little bit about the report we just issued for the Public Policy Foundation, is the block grant. In other words, as John already mentioned as part of our report, the fundamental problem here is that we have no responsibility either at the national level or at the state level to have a clear, defined budget. I want to take you back, it's not a perfect analogy, but I want to take you back to 1996 when welfare reform passed and President Clinton signed it. You need to read those debates again about what happened. You look back now, 16 going on 17 years later, and it looks like relatively settled policy. But at the time it passed, it was hugely controversial. And people were arguing that the result of it would be that huge numbers of poor people would be out on the street and their conditions would be much, much worse off. The truth is that was totally, completely, utterly wrong. When the block grants passed in 1996, the caseloads fell at the state level by about a half in a period of about 18 months. And it had been stable for like 3 decades. So there was a number of people on welfare, very, very stable for a very long period of time. The federal government passed a block grant to the states saying, hey, you decide who should be on welfare and who can go back to work. And within months, literally months, the states figured out how to move about half of their caseload off of the program back into the workforce. So when you change the incentives, behavior changes. Now, obviously, medical care is much, much more complex. By the way, incidentally, studies have been done showing that the earnings of those families was far better than it would have been if they had stayed on welfare. They earned a lot more money, much more than they were going to get in welfare payments, on average. So it was an absolute success. And so successful that you never hear anyone saying they want to undo it. No one says, you know what, we need to go back and undo that block grant concept in the welfare program. We need to reinstitute the way it used to be. Nobody says that. Now, obviously medical care is a much more complicated situation. It's got much more volatility. The numbers are immense compared to welfare cash payments. But some of the basic issues are still the same. And what I have here is some of the big key questions that we're going to have to face as we design a federal block grant, and also think about what it means at the state level. And the first thing to think about is, what do you base the funding on? And obviously, if you take the welfare example, it's most likely going to be historical rates. That seems to be the fairest way, the easiest way to go about it. But there are a lot of complaints at the state level about the current allocation being quite unfair. Some very big states, unnamed in the northeast quadrant of the United States, have huge amounts of Medicaid funding from the federal government. And some states, maybe with a little farther south, don't get as much. So, and it's also in part because of the eligibility rules. So there's a complicated equity issue that goes into this. Would you do it on a per capita basis that allow the states to get paid on a per person amount rather than a fixed total amount, allowing the enrollment to go up and go down, but the federal government's contribution to the per person rate to not change? That's one way to go about it too. That actually is something that President Clinton, believe it or not, toyed with back in the 1990s. What is the growth rate? Do you tie it to the economy? Do you tie it to medical inflation? Do you do something for population growth? There's migration. Governor Perry was obviously mentioning that there's a lot of people moving from California to Texas. Do you adjust that in the block grant? Do you do a recession adjustment? When there's downturns, enrollment goes up. The question is, how do you handle that when you have a fixed funding amount? And do you have any remnant national standards? Politically at the national level, there's going to be a lot of hue and cry when you talk about a block grant saying, hey, the states are going to throw everybody off, just like they did in 1996. And so the question is, what happens to those national standards? At the state level, I think the big question is, do you kind of think about this as one big program or segment the program? It's the problem, the issues with these populations are very, very different. You really have, in Medicaid, an acute care population, people that use Medicaid to get their primary and acute care insurance, just like health insurance in the employer setting. And they tend to be working age people, non-disabled. Yes, they have some other issues that come with it, but they're generally using Medicaid as a health insurance system. Then you have the non-elderly disabled, the people who have really serious special needs in terms of chronic problems with disabilities and the care that needs to be brought to bear to make them be able to function on activities of daily living basis. And then you have the very frail elderly, which are the most expensive population. And what do you do about them? They're often duly eligible for Medicare and Medicaid. Dealing with each of these populations somewhat differently in a block grant context may make sense at the state level. And I want to talk a little bit about, I'm going to hurry through these slides because there's too much information, but I want to talk a little bit about what we wrote up for the Public Policy Foundation in the report that John alluded to, Assuring a Future for Long-Term Care Services and Supports. The concept is, what do we do about long-term care in the context of a block grant? And the basic concept that we really want to move toward is thinking about the entitlement to long-term care services in an entirely different way. Right now what we have in the Medicaid program is the state trying to manage the service provision, the cost of the services, the need for the services on a per-person basis, negotiating with many, many contractors, overseeing the quality, trying to do essentially the service delivery on behalf of the patients. And there's a movement that's been afoot, it's been there for a long time, where people have asked, even in the disability community that are benefiting from the program, to have more control of the resources because they see themselves a great deal of things that they actually don't need given to them, or things they do need not getting enough of. And so they would say, look, if you just gave me the resources, we could direct it better than having the state control it so much. And we agree with that concept. What we need to do is then move away from a defined benefit approach to this to something like a defined contribution where, based on the acuity of the disability and the financial needs of the person, provide a fixed amount of support to them through the Medicaid program and allow them to direct those resources to the services they most need. Obviously, some of the people on this program need a family member to do that, or a surrogate to do that on their behalf. That can, of course, be arranged. The state of Tennessee is moving in this direction as well. An exception can be made for long-term care, or for nursing home care. In other words, for people that are potentially in need of nursing home care, you could have them get this kind of defined contribution payment, and then if they actually do need to go into a nursing home, kick them out of that basic structure, put them into a nursing home system that is competitively bid and selectively contracted, as John Goodman alluded to in his previous remarks. I think that is the way to get the incentives right in the program, to get costs under control. It's obviously a much more complicated proposal than just that, but that's in a nutshell what we recommended. And we think it could be a very big part of the solution for Texas and other states going forward. Thank you.
Well, we're off to a good start. Good morning. Thanks again for having us here, Mr. Capretta. That was fascinating, and it'll play into a little bit about what I want to talk about this morning. I have to first tell you that the concept of a block grant is something that I've fought for a long time, first as a state lawmaker, but now as one of the bureaucrats. I too am a bureaucrat. I'm part of the problem. I think you've at least escaped the clutches of the bureaucracy, Mr. Capretta. But the natural instinct of most folks when they come to talk to me about block grants is, give us the list. Give us the list of things that you want to do. So what I'd like to do shortly with the presentation is just kind of give you an overview of the Medicaid system in the state of Texas, current where we are, and I know I'm preaching to the choir. Many of these things will be things that you already know, but on the outside chance there's a few folks in the audience could use just a little bit of an introduction, I'd like to do that. As Mr. Capretta pointed out, Medicaid consumes 80% of my agency, 24% of the state budget. Okay, so 24% of the state budget is Medicaid, and 80% of what we do over at 4900 North Lamar. I want to point out very quickly that even though we're the biggest state agency in terms of the dollars, the 30 billion plus a year, and also in terms of the employees, 54 to 56,000 employees, the two don't actually match up. You would think that all the employees are where the money is and vice versa, but that's not the case. Most of the employees that we had are in direct services that are not necessarily Medicaid related, but they work in the state-supported living centers and the state hospitals, and so there's by and large a few in Medicaid. I say a few, relatively few, 8,000 or so that do eligibility enrollment. And so if you take all those other folks in the private sector that we contract with in the Medicaid system, that number becomes even bigger. Okay, so what is Medicaid? As you probably know, it's a jointly funded federal-state program. It covers folks who are needy for medically to eligible needy people. The federal laws and regulations basically come in two clumps. Number one, they require coverage of certain populations and certain services to be delivered to those populations. But the laws also give us some flexibility for states to cover populations that are so-called optional, as well as some services. Now, as Mr. Capretta pointed out, Medicaid is an entitlement program. Once you are through the doors and into the room of Medicaid, you're eligible based on your category for all the services that are in there, not a fixed price, come in and when you hit that dollar limit, that's all there is. So it's an entitlement program. The states set the eligibility in accordance with federal laws and regulations, and then we later determine how much that costs after those services and caseloads have been met. Who does Medicaid serve? And this will be a lot of discussion during the upcoming, or now, not even upcoming anymore, I'm just in the habit of saying that, legislative session. First, it's important to know that we serve low-income families. They're the folks who are eligible, and in a little bit I'm going to show you some slide with a little more detail on that. We also serve children. As a matter of fact, 2/3 of the recipients of Medicaid in the state of Texas are children. You can argue all you want about whether an 18, a 19, or 20-year-old is a child, but the simple fact is that's even relatively few compared to the vast number of kids from the neonatal unit all the way up until the older kids. We serve children. Pregnant women within certain FPL restrictions, people who are elderly, people with disabilities, old and young. It's important to know Medicaid in Texas does not serve disabled, childless adults. And there will undoubtedly be a great deal of discussion about the eligibility criteria during the legislative session. Okay, this slide is going to show you as a percentage of the federal poverty level who we cover in two groups. The first is those who we are required to cover in the state of Texas. That's in the blue, the lower border. And then the optional population. So in Texas, we really only have two optional populations that we add on to Medicaid. The first being pregnant women and infants, and then over to the right of the slide, the long-term care. So for pregnant women and infants, we cover 133% as the mandatory population for participating in Medicaid, and 185% as up to 185% as the optional. You can see all the rest of them on long-term care, 220% of federal poverty level, and 74% is the mandatory. Now, the long-term care is going to include a lot of things, not just nursing homes, but community-based services, other folks with the disability. I want to point out over in that middle category, the parents with TANF children. So again, no childless adults, but those parents who have children who are eligible for temporary assistance for needy families, we cover those up to 12%. This one is one of my favorite slides. You got to look at it for a little bit, and every time I looked at it, I think or imagine a little bit more that might be in it. This is going to show the Medicaid caseload growth by a few groups from September of 1979 to August of 2012. The lowest part of that slide is the original Medicaid population, aged and disability-related adults and children. Right above that is the income assistance, those folks who get temporary assistance to needy families, by and large kids, but also a very few number of adults. Above that, the pregnant women and newborns, and while this number seems to be getting bigger on us, currently Texas, about half of the births in our state are paid for by Medicaid. You'll look and see it's a relatively small number of the actual caseload population. And then above that is the poverty-related children ages 1 to 18, and that number has grown significantly in the last decade plus. You'll see the little side note up there that says caseload growth has grown by almost 60% in the last decade. That's a huge increase, and so much of that is the driver for the increase in the budget. Now, things have changed with us in terms of our eligibility, who's eligible to get Medicaid services in the state of Texas under the Affordable Care Act. So much attention was paid to some other aspects of the ACA, mandatory insurance coverage and so forth, but those things all spill over into who we serve and the ways in which we must serve them and certify them as eligible. As you know, the United States Supreme Court said that optional, what was intended to be a mandatory increase in the Medicaid population, was optional for the states. The states could add that population if they so choose, but they were not required to at the threat of losing all of their Medicaid program. This one I love, and I'm sorry it looks a little complex at first. I hope you can read that. Basically, we're going to go back again and look at those categories along the bottom from left to right: newborns, children ages 1 to 5, then children ages 6 to 18, pregnant women, SSI and disabled, long-term care, parents, and then childless adults. Okay, that's the x-axis. Look at the y-axis, and you're going to see the percent of federal poverty level going from 0 at the bottom up to north of 400% at the top. Now, the gray areas are going to show you where Texas currently covers as a percent of the federal poverty level in each of those various categories. The yellow, with the exception over to the left, the former CHIP to Medicaid. A lot of these kids in CHIP are now being transitioned into Medicaid. But the other three areas show new optional Medicaid folks, and those go up to 133% of federal poverty level. Fact is, they go up to 138% of federal poverty level. There's a 5% income disregard. The first 5% of income is just ignored, and then that's just for them to have and not count that towards eligibility. The big thing about this slide is to show that we cover some populations more than is nominally required. You had seen that on a previous slide, but also that increase on the Medicaid optional population. Take childless adults. Currently, we don't cover them. The optional population says that we would cover them up to 133% of federal poverty level. If anybody's interested in getting a copy of the slide, it'll be widely distributed to the lawmakers so we can get you a copy, but it's fairly instructive in showing where we are right now. Okay, so what does this mean? A couple of things happened in the Affordable Care Act. First, where the federal government had previously given us wide latitude in determining who's eligible based on poverty levels and so forth within certain parameters. They've now changed and addressed the eligibility game itself. Whereas Texas once sort of had our own definition as to what constitutes a household and what that federal poverty level percent was for a household, and were able to disregard certain things like assets. If families had large numbers of assets, things that they were holding but just didn't have cash nor a lot of income coming in, Texas was able to look at that and say, we're not going to give you complete coverage because you've still got other assets that you're holding. You could sell some of those and cover some of your expenses and so forth. But the ACA changed that game. What they're now talking about in the Affordable Care Act is the so-called modified adjusted gross income. And with that MAGI, which sounds like a fairly technical term that ought to be easy to define, we're finding out in the state level it's making us change our eligibility processes. We're having to change computer software. It's vastly more complicated than we thought it would be, and we're still not getting clear direction on MAGI, as we call it, from the federal government, from CMS. If you look at this, the Medicaid ACA caseload estimates, there's two groups in there. Number one, because the ACA requires people to have insurance, a bunch of people will now be pushed into the insurance system and didn't realize or didn't care, they're healthy, they weren't looking for insurance, and come to find out they were eligible for Medicaid because they're required, and now we will find out that we have to cover them. The other group is the expansion adults, those folks in the yellow boxes that I talked about earlier. Now, those are big numbers, and I'll put them up there. The next slide is going to show, we may have taken that slide out. Relative to most of the Medicaid population that we currently serve, it's not that great. Looking to the future, and we'll do this in the panel discussion, I want to talk about the things that Texas could do if we were freed from so many of those constraints. Texas is big. Texas has a lot of folks centered in those urban populations, but Texas also has vast expanses of open territory between Medicaid populations. And so with great medical schools centered primarily in the urban areas, I would contend that along with the Texas legislature and the governor's office, Health and Human Services Commission could come up with a better system. And I know my time is running short, but I'm going to talk about some of those options that would be available to us if we had a block grant or something even closely approaching a block grant. I appreciate your attention. I look forward to the panel discussion.
Great. Well, I'm Ann Dunkelberg with Center for Public Policy Priorities, and I'm sure that all of us could each talk for an hour on this topic, so trying to cram it into 10 minutes is always a challenge. So I'm going to tell you sort of some of the, if you're not familiar with the center, we work on behalf of improving routes to prosperity and the lives of low-income Texans, so that's our goal. So I'll be presenting some of the same information and some of the different perspectives on some of the same things that other speakers have addressed. I think one of the things that's been addressed is the growing share of state budgets that Medicaid accounts for, which is absolutely true. The other piece you have to remember, however, is that Medicaid is the #1 source of federal funds in every state's budget in the union. It's the #1 way every state gets your federal income tax dollars back into their state budget. So when we start talking about the decisions to leave Medicaid options on the table, unfortunately that also goes along with leaving the ability to bring some of Texas's tax revenues back to the state. And I know that there's a whole theme of this that the Foundation is looking at now, and you'll have an opportunity to talk about it in some of the other sessions. But that's a huge issue. And as also has been alluded to by some of the other speakers, Medicaid could almost be seen as multiple programs all under one funding umbrella, although there is a lot of overlap, that it is providing health insurance coverage, sort of like your health insurance coverage. It is the only systematic provider of long-term and community-based services and supports for seniors and people with disabilities, because as those of us who are older in the room and either are approaching Medicare or taking care of our parents know, there is no long-term care coverage in Medicare. It's all being handled by Medicaid today. So that's a huge role, not only for seniors, but for Americans with serious disabilities. And then, of course, Medicaid provides both direct reimbursement and some offsets to our safety net providers, especially hospitals, and that's undergone some pretty radical reform here in Texas over the last couple of years, which probably won't be the topic of conversation today, but it is a really important development and does have some implications for the cost-saving discussion. This is another way of looking at Medicaid population in Texas. I think it helps a little bit. Dr. Janik mentioned that over 2/3 of our program is children. I do want to reinforce that we actually kick kids off when they turn 19. So we don't have to worry about whether we really think 19 and 20-year-olds are kids. Even though in some parts of federal Medicaid law they're treated that way. In our Texas Medicaid program, they lose eligibility on their 19th birthday. And you may feel grumpy about those 17 and 18-year-olds, particularly if you're raising one right now, but that's the age group we cover. In addition to over 2.5 million kids on Texas Medicaid, we have just under 600,000 additional kids who are enrolled in our separate CHIP program. Then the other two largest segments of the population are folks with serious disabilities, most of whom collect supplemental security income, and typically that's their only source of support. Then we have another group of seniors, many of whom are also living on around 75% of the federal poverty income level and qualify for supplemental security income. In both of those groups, we have a group of folks who are a little bit over that income limit, which you've seen on one of Dr. Janik's slide, and I'll show you again, who only qualify because they either qualify, they have the medical necessity for nursing home care or some other kind of serious long-term care need. Then finally, we get down to the parents. One of the things that is different about our Texas Medicaid program than was described by Dr. Capretta is that we actually don't have a population in Texas Medicaid that are just using Medicaid like regular insurance. Because we have chosen as a state, because that's one of the flexibilities that current Medicaid law provides to state, we have chosen not to cover parents on a par with the children. So we have a situation today where we have almost 2.6 million kids in Medicaid and fewer than 250,000 of their parents qualify. So that's one of the ways that we stand apart from some of the other states on how Medicaid is used here. And then finally, as was mentioned, we have in any given month around 90,000 women who are getting maternity-related Medicaid. That terminates 2 months after the baby's born. It's temporary coverage, so there's not long-standing coverage for those women. And it is important to note that we have poor parents on the program who are poor enough to get cash assistance, but they're not getting it. We also have a smaller number of parents getting cash assistance. And in August, there were only about 82,000 Texas adults getting Medicaid because they qualified for TANF. So in Texas, we really did end welfare as we know it with welfare reform. We have a very, very tiny number of people actually getting cash assistance anymore. And that's not the basis for getting Medicaid for the vast majority of Medicaid recipients, and that's been the case for over 10 years. This is pretty much the same chart that Dr. Janik showed you. I'm just going to touch on, maybe because we wrote some of these back in the first Pink Book in the 90s, but in any case, I think the optional populations, all of those yellow things are things that Texas didn't have to do at the time. It is important to notice that right now, they were optional when we did them, and I want to give us credit for having taken, gone that extra mile. They're not technically optional for us now because those things are still subject to maintenance of effort requirements, so we are not in a position to lower those eligibility limits at this point. And then you'll notice those really short bars, the same one. I have 2 bars for parents. Dr. Janik shows you the income limit for a parent who's not working at all. So the example I usually give is, say, a mom with her kids who's just gone to a domestic violence shelter. So she suddenly is living on air. She has nothing. So that's who your 12% of poverty parent might be. And that means that if mom and dad, when she moves to the shelter, give her more than $188 a month to live on, she would lose her Medicaid. That's how low the income limit is for her. But if she were working, say she moves out of the shelter and into the transitional living center and she gets a job at minimum wage, she could keep that. She would be able to keep a little bit of her earnings, but still, if she got up over about $300 a month, she would lose her Medicaid as well. So even with the income disregard, it's a tough program to stay connected to as an adult. Why are so few parents covered? That's because the Texas legislature set that dollar limit I mentioned, that $188 a month for a family of 3. That dollar amount was picked in 1985 and as a fixed dollar amount with no inflation adjuster, and it's never been updated. So every year the percentage of poverty that parents qualify for in Texas here gets smaller, and If any of us remember our college math, there's that thing about numbers that a line that approaches but never reaches zero. So that's kind of what we've got right now in our coverage of parents. But that's why it's a very, very meaningful program for Texas children. It is not a meaningful program for parents in terms of acting as a normal kind of insurance package. Important to understand, I think everybody knows Medicaid doesn't cover undocumented immigrants at any age. And in Texas, we don't cover legal immigrant adults either. We are covering kids until they hit that 19th birthday in Medicaid and CHIP, but not adults, even if they have a green card and permanent residence. So this is part of, I think, a lot of my approach to talking about the block grant concept in Medicaid and what our concerns are as advocates about going in that direction has to do with trying to bring people around to understanding that we don't have a special problem in Medicaid. Medicaid is not especially expensive or growing especially fast. We have a problem in health care. And the solutions to getting Medicaid spending, what we do have is an obligation as a state to pay for part of Medicaid, and we don't have to pay for part of Medicare, and the state's obligation for the general health care costs is limited to just state employees. But the solutions to getting healthcare spending under control are the solutions to getting Medicaid spending under control. There's not some special problem in Medicaid or some special solution for it either. This is one of the things I showed at a Senate hearing last summer, and it was a joint hearing, and one of the members came up and grabbed me afterwards. A conservative Republican said, "I've never seen this chart before. What on earth accounts for this?" Well, this is the United States and all of the other industrialized countries, almost all of which have universal health care. And in Texas, in the United States, we're spending almost $8,000 per person on health care, even in a country where 40-some-odd million people don't even have health insurance. Meanwhile, in all these other countries, our next closest competitor, which I believe on this chart is Norway, and followed by Switzerland, are spending $5,300, $5,100 per person. You never hear anyone talk about that crummy Swiss healthcare system or that lousy German healthcare system. I mean, these are very good healthcare systems, and they're doing the job for virtually everyone at a whole lot lower cost. So we have a really big challenge ahead of us to try to figure out how we can do what they're doing, but in a way that works for the United States with a different set of priorities and values. This is part of the answer that I sent to that representative when he asked me what's going on here. You know, why is it so much more expensive here? And unfortunately, it's not a super clear answer. I mean, basically, it looks like we are spending more in every area proportionally than all of the other industrialized countries are. So it's not just hospitals, it's not just doctors, it's not just drugs, it seems to be all of the above. Here is a slide that shows you the per capita increase over the last decade of costs in Medicaid, then Medicare, then private per capita expenditures comparable to the Medicare package, so defining that benefit package, and then private employer insurance premiums. And so you can see Medicaid and Medicare have been growing on a per capita basis much more slowly. More people are going on to Medicaid in every state, however, and it's especially kids, as we've noticed before. So that's what's driving your cost up, not the cost per person. We've actually lowered per person spending in Texas Medicaid over the last decade. Particularly if you adjust for inflation, we've dramatically lowered it. So as many of you know, the reason for this is because the rates that are paid in Medicaid and Medicare are lower, and that's one of the reasons why. It also has relatively low administrative costs. But that's bringing you back to the fact, these are very expensive programs. We have to get their spending under control, but there's not some special problem there that's unique to Medicaid and not to the other folks. This is another example of comparing public insurance to private insurance. We have a lower per capita cost in Medicaid than we do in private insurance. So here's the concerns that come up, and I think Dr. Pereira reflected on this very well. Our concerns with block grant are these. This chart is all the states by their per capita spending on Medicaid, and Texas is not all the way at the bottom, but it's somewhere there in the 30s, and or maybe the low 40s, so high 30s, I think. So you can see that our per capita spending is considerably lower than the national average. And one of our concerns about a block grant is if I could design the block grant, if the intentions that go into designing a block grant are such that You are concerned about things like, what do you do when there's a recession? What do you do when there's a big breakthrough in medical technology so that there's suddenly something that you want to be able to spend more money on? What do you do when there's a natural disaster? What do we do about the fact, that you need, if you're going to have a block grant approach, you have to have an answer to those questions. And if the answer is no more money, then obviously it's not as good a deal for Texas. It turns into a cost shift either to the state government to take a block grant or to the recipients themselves or the healthcare providers. And then I'm going to have to wrap it up here in just a second, but it also would lock us into, literally, we could find ourselves being locked into something like a $5 billion IOU. Or in addition to the $5 billion IOU that we wrote for Medicaid in our last budget, we also cut an additional $2 billion in state GR. We don't want to be locked into those things. We have only increased professional fees for doctors and other professionals in Medicaid 2 or 3 times over the last 2 decades in Texas, and we've cut them an equal number of times. So we have kind of a flat situation for what we pay people, just like we've kept that income threshold for parents flat. So we don't want to be locked into those things. And if we have that kind of block grant for Texas, it could be a real problem for us. I'm going to show you one picture. This is the Maternal and Child Health Block Grant, Title of 5. And it has dramatically lost buying power over the last 20 years. Congress has not made any attempt to keep it up with inflation at all. And so the devil is in the details. Our CHIP block grant was the first block grant Texas had ever gotten where they attempted to construct a block grant that was based on need in a state and not historical spending. So the bottom line is, unfortunately, if we start with historical spending, it could be a very bad deal for Texas. And you want the program that is paying for 7 in 10 nursing home residents and more than half the babies in this state to be solvent. So if we move towards, there is no doubt that we have to move towards cost constraints in Medicaid and Medicare, and we're going to see austerity in both of those programs, but we're also going to see austerity in our own health care because we have to get health care spending as a percentage of GDP down, not just Medicaid and Medicare. That's, the problem doesn't end at the edge of the federal budget. So basically, our biggest concern as advocates for low-income Texans is I want to see real savings in Medicaid. I want to see a comprehensive, decent standard of care, and I oppose false savings that really are only cost shift either to the state or to the beneficiaries or to county governments, which is where we leave a lot of our responsibility for the uninsured and underinsured in Texas. And I'm sorry, I'm going to add one more thing. One reason when audiences ask me why this is so hard, one of the things I tell them is part of it is because we have a big part of our system is formally for-profit. And when you are a for-profit entity, your job and your responsibility to your stakeholders is to maximize profit. And as some of the earlier speakers indicated, sometimes things that you are doing that are very profitable in healthcare may not actually be cost-effective or improving people's health. And it is real hard to get anybody who's doing that, not just your for-profit providers, but your nonprofits and some of your publics as well, to change their ways. And so this is one area where the pure incentives, even of a well-constituted market, won't always drive the most cost-effective care unless we can find a way to demand that you only get paid if your care is not only a good price, but also of a good quality and has good outcomes and cost-effective. So I appreciate your indulgence in letting me run over a couple of minutes, and thank you very much.
If there's any questions, we can continue the discussion up there. There's a lot of healthcare professionals in the room, and surely there must be some questions. Yes?
Yeah, you stated at the end there that you didn't want to, quote unquote, shift the costs onto Medicaid beneficiaries. And my question is, why not? Aren't people better capable of shopping for and taking care of their own healthcare needs than some bureaucrat?
That's a good question. Since it was directed to me, I'll start with it. I'm sure everybody else will have comments too. I think one of the things you have to remember, and I think Dr. Capretta, or maybe it was even the previous panel, made a reference to the fact that some people are going to need help with that. By definition, Medicaid includes a whole lot of people who have intellectual disabilities, serious chronic mental illness. They are very, very old. They are children. So there's a lot of people in there who aren't necessarily capable of guarding their best interest. Medicaid policy does allow for some cost sharing, and Texas law has been on the books allowing it for several years now, but we haven't moved forward with it for a variety of reasons that probably are too dull to go into right now. But I think there are some advocates who just are totally opposed to cost sharing at all. I am totally ready to take on the cost sharing that is allowed under federal law for Medicaid. We haven't tried that in Texas yet, and certainly if we move forward with the Medicaid expansion under the Affordable Care Act, which would add 1 million or more adults, parents and non-parents, to the program, that would be a population where it would really make sense to be moving forward with those co-payments. I want to remind you that when we're talking about seniors and people with disabilities on Medicaid, most of them are living on $700 a month or less. So it's not like there's a lot of serious contribution towards the cost of care that people in that income group can do. When you look at the ACA structure, the cost sharing obligations become very significant, much more significant when you go above that Medicaid line, and you have families really on the hook for up to 15 to 20% of their income if they have a bad year with a lot of healthcare costs. So they would cap out at anywhere from 15 to 20% of family income under the ACA. And I just think it's more appropriate for people, once they're sort of, past the point where they can reasonably be expected to keep the lights on and not run out of food for the last week of the month. That's where we look for the cost sharing, and we have it in CHIP.
May I make a point? Go ahead to address that. If I've not learned anything over practicing medicine for the last 25 years, it is that people will always spend someone else's money much more willfully and with less regard to the consequences than they would spend their own. If you look at the Texas Children's Health Insurance Program, CHIP, it has been far less controversial. Part of that is because it's a much smaller number and a much fewer number of patients, clients, as they say. But I think part of it is also because we put the premium sharing in there. The premium sharing for being in the program to begin with, as well as some co-pays in there. I agree with Ms. Dunkelberg. You can't make this so onerous on people they simply cannot afford to go to the doctor. That's being penny wise and pound foolish. But if you look at the history of the Children's Health Insurance Program, I was a member of the legislature when we voted on it. I was opposed to it because we didn't know the back end of where the expenditures would stop. But at the end of the day, I voted for it with one provision. I asked leadership, because the votes were there to make it pass, and I asked leadership, just make sure that the premium sharing, the cost sharing stays in there, and then I will vote for it, which I did. You can question my sanity for voting for it. You may not think that was a very good judgment call, but I think that provision, making sure that people had some skin in the game, is enormously important. Enormously important in terms of the mindset. One more thing about this, and I'll be quiet, and that is that it's not just about whether they'll behave responsibly. We would love to create a system where people in need in the state of Texas don't feel trapped in that system, but rather feel like neighbors are going to give them a hand, help them gradually get themselves out of that mess. So the more you make, the more you pay in terms of premium sharing or co-pays and the like. So we can stair-step that, as we've done with the Children's Health Insurance Program, to give people a path to independence. Right now, if somebody says, you know what, I could go to work next week and I could get a better paying job and I'd make $5,000 more, but in terms of what I would lose in real benefits from Medicaid, it's not worth it to me. I'm staying where I am. We can trap people in that cycle of dependence. So while we don't want a system that's onerous on people and discourages them from going to the doctor, for example, we do want a system that will give them that path to independence. That's one of the flexibilities that we would like. Real quick, and I'll make this brief. State of Arizona recognized a common problem. We have it here in Texas. Estimates from some of our pediatricians and family practice people are that half of the clinic appointments go unmet. Doctor says, why am I going to take on more Medicaid patients when half of them don't even show up? Okay, so maybe we've got a little bit of a stick along with a carrot. Maybe we say, if you don't show up, you owe the Medicaid system or that provider something. You owe them something. The state of Arizona tried to do this, and the Fed said, good idea, we'll help you with charging people for a missed appointment, but here's the thing. First, not $25, $3. Okay, well, maybe that makes sense in terms of the economics. Oh, and by the way, the doctor's office has to call every patient 24 hours ahead of time to remind them that they've got an appointment that that patient made, and they have to give them either written notice or telephone notice, however the patient prefers. The doctor's office going, we spend a fair amount of time on the phone to begin with, and feds go, wait, we're not through. Oh, and you can't do it in Pima or Maricopa counties. That's where everybody lives. Feds wanted to say we gave them flexibility. It's a ruse. It's a joke, with all due respect to our friends in CMS. It's an absolute joke. And yet they were able to say, yeah, we gave them some flexibility. We need true flexibility. We can build a system in Texas that gives people a path to independence using the resources that we have. And if time allows, I'll talk about our state-supported medical schools. We can do better than this. It's just that I can't be constantly going back to Baltimore, Maryland, asking, Mother, may I? We need flexibility.
Let me just interject one thing. I haven't heard you talk about the cost of medical attention and that sort of thing is going out of sight, and it's unrealistic. You know, you get a $100,000 hospital bill, and they get a $40,000 payment, and they're satisfied with it, and things like that. The cost of medicine, every time the federal government gets into something, the cost goes out of sight. And you're not talking about that. Is there some way we can bring some logic and reasoning to the costs of medical services?
Well, I want to address that question. I also want to just mention that Ms. Dunkelberg referred to me as Dr. Coretta. It's nice, but I'm not a doctor. Yeah.
I'll call you president from now on.
Yeah. I'm not a doctor in either sense of that word. But with respect to your question on what's the fundamental issue in the cost of care, it has to do with the fact that, as you indicated, that when the federal government gets involved and subsidizes third-party payment, and it does in a big way through Medicare, through Medicaid, and through employer-sponsored plans, through a tax benefit that goes to employer-sponsored plans. It's less, but it's still there. We have a system heavily dependent on the providers of services being paid from someone other than the actual person in front of them most of the time. Now, in a catastrophic event, that's why you need insurance. Nobody has, most of us don't have $50,000 laying around for cancer treatment for us over the next year if that happens. So we would need some insurance against such an expensive event. However, even the process of buying the insurance that's going to pay for that coverage is totally insulated in a lot of ways from the consumer. So what you need to do is, as Dr. Goodman has preached endlessly over the last decade, you need to build a real marketplace for consumers to be purchasing their coverage as well as purchasing the services they get. And if you do that, getting back to what Dr. Janik just was talking about, if you do that, it doesn't take 100% of the people to be active consumers. Not all of us go out and read the entire fine print about our smartphone contract. In fact, I would say 1% of the people do, right? But the marketplace basically works because 1% of them do, and they kind of keep the system in check by saying this is cheaper than that, et cetera, et cetera. So there's been lots of studies showing that if you just have an active marketplace where a lot of consumers are available and purchasing coverage, and you got 10% who are trying to figure out what's the best deal, the rest follow. And the system becomes more efficient over time. And that's true even in a Medicaid population. That you don't have to it doesn't have to be massive cost sharing on the part of the participants in the program, but you need to have some, so that the whole system becomes more responsive to the fact that if your costs get out of control, the consumer is saying, hey, wait a second, is there a better way? Can I find isn't there a way that I don't have to pay $25, but I can pay $15? And when you start to do that, it happens. The Medicare program created, it was controversial at the time, and it still is, created a drug benefit in the Medicare program in 2003. Cost the federal government a lot of money, but it was essentially a program where the consumers had to pick the plan they wanted. And the program has come in essentially 40% below what was expected. Premiums have been flat for the last 3 years. And it's all driven by the fact that the seniors who are signing up for their drug plans, surprise, don't want to spend a lot of money. So they say, you know what, I'm going to try to find a plan that's covering my drugs, more or less, at the lowest premium. Now, is it a perfect selection? Do all the seniors pick the right plan exactly for them? No. But by and large, most of them migrate when the premiums get out of control. There is movement to lower cost plans. You need to do that across the board in the health system. And if you do that, then the craziness of some of the prices will start to moderate. If the federal government, though, tries to do it for the whole system, the federal government says, hey, prices are crazy. We are going to come in and set the prices for the whole system. They'll get it wrong at least half the time, and be too high half the time and be too low half the time. They'll never get it right.
If I may, quick thing about costs. You have to be careful with that term. You have to look at who's asking it and how they define it. Governments will define cost as how much money was spent. Spent $1 more this year than we did last year, therefore costs went up $1. In healthcare, as with many other things, cost means more people in the system, it's one driver, more people utilizing more services, so 10 more people, and rather than each person using one service, each person now uses 1.4 services. So more people, each person utilizing more services, and then those services do cost more. Part of that is driven by typical low inflation, 5%, but also medical inflation is typically higher. I would argue that medical inflation is typically higher because people don't have skin in the game. They don't want to sit across from a doctor and say, tell me the way to get at this done that's going to save a little bit of money in my health savings account. Real quick anecdote. 15 years ago, one of my best friends from kindergarten, this guy was my best man at my wedding, he called me. He was married, his wife was pregnant for the first time, and he said, hey, Debbie's pregnant, as you know, we're getting close to the due date. What does an epidural cost for labor? And I said, well, it just kind of depends on what insurance is going to cover, and maybe there's a discount for this or that, but primarily it's driven by the insurance. He goes, no, we don't have insurance for maternity coverage. I said, Steve, buddy, you work for State Farm. You've been selling me insurance for a long time. Please tell me that. He said, no, we have health insurance. We don't have maternity insurance. We saved the money. We put the money aside through the years. And so we've got catastrophic coverage if the baby is sick or if Debbie gets really sick during pregnancy, but no, just for paying the obstetrician for delivery and paying the hospital, no. I'm going to go to the anesthesiologist and say, what do you charge? And I'm paying right now. Now what do you charge? It's a mindset. It's a cultural change. We can't put an unbearable burden on poor people who cannot afford it, but we can change the culture by saying to people, you're not dependent on us, we're partners here. You pay something, we'll meet you along the way. We'll get you through this crisis. Hopefully it's temporary for your family when you're down on your luck. We cover kids that we may need to cover, maybe kids that we don't. We do cover up to age 21, by the way. Many of those are kids in foster care, and Medicaid continues to cover them even after they leave foster care. So we do cover some of those kids. It's not many. Ms. Dunkelberg's right in the grand scheme of things. But creating that culture where people know that they're going to partner with the government, not get something for free and then be trapped in that system forever. It's a far better way. The way to do that is that the federal government will give me that latitude. It's not me. It's Senator Larry Taylor. Give the legislature, Representative Capriglione, I think is here, give the legislature some latitude to create a system with Ann Dunkelberg at the table, advocating for amendments on the floor and that sort of thing. We can do better than our friends in the United States Congress.
We have time for one more question.
dovetailing on what you just said, a question about efficiencies in the system that we may have more direct control over, talking about CHIP and Medicaid. Just wondering if you and your team have had a chance to look at maybe some of the ways to save some costs, or maybe this is kind of a drop in the bucket, in terms of CHIP versus Medicaid. You know, we've had some constituents and issues where, you know, just trying to get into the system when you need the services, that it is such a crazy quilt system, and even within HHSC, it's, well, you know, for children's Medicaid, the office is in one location out in Odessa versus CHIP is up in Dallas-Fort Worth, and trying to figure out how to navigate the system. And, oh, if your income is over one thing, then your application's going to go to CHIP, and it might get back to children's Medicaid, and it's very frustrating for the applicants, and maybe cost saving of consolidating staff. And then a second part to that is, what would happen if right now Texas, to save the budget cuts a few years back, went to every 6 months applying for having people reapply for Medicaid. Has there been any real cost savings from that versus when we were doing it every year? If you could maybe look at and elaborate on that.
Two pieces, but I'm going to leave some room because I know Ms. Dunkelberg will want to weigh in on those. The first is, are we as efficient as we could be? Absolutely not. We could be far more efficient. Some of it is us. That's what we look at every time I walk through the doors at 4900 North Lamar. These are the kinds of things that my team and I work on. Where can we get better instead of pointing the finger at the feds, right? So we're trying to get better. It makes no sense that in the old scheme, people had to go to the state office and stand in the line and take the number on the lunch hour. Why can't we do better in getting people determined eligible for Medicaid using web portals? Now, a lot of poor people don't have a computer. It's okay. The food pantry where they go does. The church that I deal with does. The United Way does, and those local partners are willing to help me get those people determined whether they're eligible or not. We're not there yet. I have about 8,000 eligibility workers. I'd like to be about half that. And by the way, there's nothing conservative about telling somebody who is eligible for state services, we're going to make it really hard for you to get there. You got to want it badly. That's not conservatism, and that's not the conservatives that I know. What we're talking about is making it difficult to defraud the system, and I could talk for another hour about fraud, waste, and abuse, making it difficult to defraud the system, and making sure our criteria are clear for all, no wantonness on the part of bureaucrats. I don't like the way you look, come back another day, bring me the witch's broom, and maybe I'll make you eligible. Criteria need to be clear, they need to be known to all. Computers can do this in such a way that we can determine very quickly by querying database. Where do the feds come in? Feds insist that I have a state employee. I can't contract out that expertise to a company that is good at determining eligibility and does it in 15 other states. The feds insist that I have a state employee, not a contractor, to determine eligibility and make the enrollment. I think I can do better if I can get that latitude.
I just wanted to clarify on the terms of eligibility you were asking about. Children in Medicaid renew every 6 months and have continuous eligibility. Children in CHIP renew every 12 months. Adults on Medicaid, if they're some of that tiny pool of parents we were talking about, they're still eligible month to month. So we've got all kinds of different policies here, and I'm not sure where you were going with that. When we did go from 12 to 6 in CHIP, it caused 200,000 children to drop off the rolls, a reduction of children covered of about 40%. So that was one of the reasons it was reversed. It was like adding another drain to the bathtub without turning up the tap.
What we can do, I think, is that, and Ann and I don't think have discussed this, but by not putting a burden on the family, but we can query databases to find out whether somebody's recently been hired. We can query all sorts of databases without bothering that family at all to see if their financial considerations have changed. And in doing so, then find out, oh, suddenly you got a job and you're making good money, you're back to work, we're happy for you. Let's talk about whether or not you're still eligible for Medicaid or CHIP. And we can do that, we just need to do a better job of it.
I just want to point out we have panel evaluation forms over here on the side table. We also have updated schedules for the rest of the day. Please join me in welcoming or thanking our panelists for this.